Good evening, everyone. Thank you for being here tonight. My name is Pauline Matindan Garcia. I am the Director of Care Transition for Livingston Memorial, VNA and Hospice. I will be moderating tonight's presentation. Our topic this evening is aging well. But before I introduce our speaker, I want to just go over a few housekeeping notes. Tonight's session, as you know, will be recorded and available for viewing in a few days once it's posted on our website. If you have any questions for our speaker during the presentation, please feel free to use the chat function, the Zoom app, to submit your questions. We will do our best to answer all those questions. If we're not able to get to your question during the presentation, all the questions and answers will also be posted on the website along with the recorded presentation. If you run into any IT issues, technical issues, please use the chat function as well to submit your request so we can provide you with some assistance. So tonight's speaker is our very own Dr. Lanyard Dial. Dr. Dial is a geriatric medical specialist. He has been Livingston's medical director since 1985. Dr. Dial is also a certified geriatric physician and certified in hospice and palliative medicine by the American Board of Family Medicine. As a longtime Ventura County resident, Dr. Dial works to improve the quality of medical services for the elderly, homebound, and terminally ill. Dr. Dial graduated from the Washington University School of Medicine in 1981. For more than 20 years, he was in medical leadership roles at Ventura County Medical Center, culminating with his tenure as medical director for the Ventura County Healthcare Agency. He also served as Livingston's CEO from 2007 to 2021. So it's my honor to present to you Dr. Lanyard Dial.
Thank you very much. Hello, everyone. Tonight, our topic is aging well. And I have the opportunity to share my screen and show you some of the details of that presentation. And as you've done before, you're welcome to ask questions in the chat box or live as we finish the presentation. And we'll go for 30, 45 minutes to try to help you understand this topic. So let me begin and share my screen. Aging well. We are all going to age, and it's important that we spend a little bit of time understanding what that means and how to age as well as we can. This is one of my favorite slides that I use very frequently as I'm talking about geriatric topics with people, because I think it pictorially depicts what happens to us as an individual as we go through our life. We start young, being able to almost not crawl and then stand up on our legs and start to walk. We develop into mature teenage years and then into mature individuals, and then start to decline and start to have loss of many of our functions and have growing debility. That is aging. That will happen to all of us. There's no escaping that. Everything that is born or is alive ages. Whether you look at flowers, elephants, ants, anything you can think of that is alive goes through a process where they begin as a seed or a small birthed animal that then grows up and then ages and eventually dies. That's the process by which we as any living being go from small to mature to elderly and dying. We're going to look at how do we do this process, particularly the last stages of this, well. We're set in how this goes in some ways because we're all a product of our genes. And your genetic makeup allows you to develop as your genes allow you to develop. And the diseases that you get through your life, some come because of your genetic predispositions. But what we'll look at is what can you do to age as best as you can through your lifespan. One of the key aspects of that has been the development through modern medicine of understanding the diagnoses, the diseases that affect us, and how to treat them. In addition, modern medicine has developed vaccinations, various types of and ways of treating illnesses with medications and with surgeries, and many other things you know about, whether you look at immune therapy or radiation treatments. Medical care has been essential to our aging as well as we can. We are confronted throughout the aging process with a variety of illnesses that then medicine can help us treat so that we can get to a point where we also grow old with those diseases being treated by medicine. However, what that presents us with are older adults with a variety of major diseases. You will survive your pneumonias when you're young. You will not get bad illnesses because of your vaccinations. You have treatment for your high blood pressure. But through your life, because you will now grow old together, all of us, you will develop degenerative arthritis, a very common, frequent problem in our aging population. And that's because we can't eliminate that. We have not been able to get rid of degenerative arthritis. We use our joints, and yet we treat people with both surgical and medicines to try to keep those joints as good and as active as they can be. Cancers that used to take our life are now treatable. We don't get rid of them, but we can treat them. And in some cases, you can totally eliminate them. Cancer that used to cause people to die in their 40s or 50s can now be treated so people can live into their 60s and 70s. So part of aging is the understanding that you will develop an illness, which then medicine will treat, not get rid of. You will persist in having that illness, but we will be able to keep you alive longer and longer. Kidney disease. You're probably aware that throughout an aging lifespan, your kidneys can live to be about 110 years old. But you lose kidney function throughout your life as a natural process of aging. So following your kidney function, making sure that when your kidneys start to decline, you're on the right treatment for that kidney disease. And ultimately, you can go into dialysis or have a kidney transplant if your kidney becomes your major issue with kidney disease earlier in life. Heart failure and vascular diseases are extremely common in our current population. We have found ways to manage the chronic hypertension, to manage lipid disorders, to deal with revascularization of your heart so that you can live a longer life as your heart starts to have trouble or as your vascular disease develops. So heart failure, very treatable. You may develop it in your 50s, in your 40s, and we can treat it and keep you alive longer and longer. Heart disease is another one where we've developed transplantation options for people, and you can have a heart transplant. These days is fairly standard. So heart disease and vascular disease, huge problems in our current population of people, with our understanding even of all the variations, we do our best to treat people so that we can prolong their life with heart disease and vascular diseases. Chronic lung disease, another one of the major organs that gets damaged through our lifespan. That comes up a lot with smoking, and as you are well aware, we have been on quite a trek to try to eliminate smoking in our population. However, many people still have a problem with smoking and they develop chronic lung disease. And many people who stopped smoking many years ago still have lung damage from that smoking episode. You can get non-smoking related lung diseases. There's an illness called interstitial fibrosis that we don't know what causes it. And you end up with lung damage from that. So lung disease, heart disease, cancers, all of these are very treatable illnesses that we can help you stay alive longer with. I get to the biggest bugaboo in the major chronic disease world in our senior population, and those are the neurologically degenerative diseases. Illnesses of the neurologic system we understand, but we have yet to develop good treatment for. Vision loss from an illness called macular degeneration, which we can identify. There are a few treatment options to try to prolong an individual's vision. But certainly Parkinson's disease and all the dementias are degenerative diseases of the neurologic tissue. Those illnesses we don't have treatments for yet. I'll add on top of that list amyotrophic lateral sclerosis, which is Lou Gehrig's disease. Very similar diseases, Alzheimer's, Parkinson's, Lou Gehrig's disease, Lewy body dementia. Damage to brain cells that begin at some point, and hopefully in your life, they begin late enough in your life that they don't affect you too much in your early years. But if they begin early, we can help you through some of the symptoms they create. But as of yet, major medicine has not found a way to stop these illnesses. So what I wanted to do here is paint the picture that you're going to age. Just based upon aging alone, you will develop problems as you get older that I can help. But in addition, and help you manage. Some of them you will live with for the rest of your life, and some of them will take your life shorter than longer. So these are the major chronic illness that we need to look at. You know, age is a really interesting thing because it is still in our country, and recently all the news from France talks about people in their 60s. 65 to 75-year-old people are incredibly strong, incredibly capable. We have a society that has gotten better nutrition, better physical activity, and so young old people are the 65 to 75-year-old group and are fairly active. The middle-aged individuals, I say, are 75 to 85. That's the group where age-related changes, you're going to start to see problems. In fact, the many individuals develop trouble with falls, trouble with disturbances of their joints, the beginnings of some progressive Alzheimer's-like diseases or dementias happen in that age group, that 75 to 85-year-old group. That's also the group where cancers start to develop more commonly. So that is an age group that I would say fall into the old category. Now you get to the oldest of old, those individuals 85 and over. You may be in that age group, and you may have come to see the disabilities that aging has created, and the number of illnesses that have crept in that cause you even more difficulty. This is an age group where their orthopedic issues are significant, where their dementia issues are significant, where new cancers come up. The oldest old, if you're able to escape major illness and you keep yourself active, even involved in things that go on, you can get out to 90 to 100 these days and still be in good shape. So my early diagram showing the aged individual doesn't have a specific date or age at which you start to fail, but this is a group that we look at. In fact, when you start to develop services to provide care to individuals in our communities, 85 and over is a huge target group because they need a lot more assistance with doing their activities. And what I want you to take away from this, one of my big points, is age matters less than function. And so talking about or working towards the idea of function is much more important. And this picture just shows you individuals who are staying active and involved and the ages at which they're doing things. But let's talk for a minute about function. What I mean is, irrespective of your age, what are you capable of doing? Can you, as this woman in the bottom left here shows, sweep your environment? Can you clean your home? Can you, as the gentleman in the top right, play tennis still? Whether you're 58, 75, or 92, what are you capable of doing? Or are you in bed needing medical care? What is your level of function? To understand function, there's language that you should be familiar with. It's language that helps you define function. It's language that when you see a physician, if you use this language, it helps physicians understand the impact of your aging or your disease on your abilities. So there's two functional categories. The first are activities of daily living. The second are instrumental activities of daily living. The activities of daily living are very basic daily living things that you do to function around your home and your environment. The mnemonic I teach with has been developed by the Mayo Clinic back in the 1980s. And it's a good mnemonic because it implies that if you're not able to do your basic activities of daily living, you're nearer death. That is, can you dress yourself? Can you eat? Get food into your mouth? Can you ambulate or move about in your environment? Can you use the toilet on your own? And can you do your own bathing? So the dressing, eating, ambulating, toileting, hygiene are scored as I can do all of those on my own without help. No, I can't do any of those. Someone has to help me do all of those. Someone has to put clothes on me. Someone has to feed me. Someone has to transfer me to a wheelchair and wheels me around. Someone has to help me either change a diaper or move me to a commode and help me wipe myself. And someone has to do a bath for me. So you're either independent or dependent in each of these ADLs. Now there's a middle. And so we typically will score them as needing no assistance, needing moderate or minimal assistance, to needing full assistance. And you can see that if you need full assistance with these, if you're totally dependent on someone helping you to do these, you've lost significant function. And if you're at that functional level, then you can see you're coming to the end of your life. Because needing and being that disabled where you need help doing each of these things means that whatever illness or age you're at, you are coming to the end of your life. So you could be 50 years old and be totally dependent in your ADLs. You could be 92 years old and totally independent in your ADLs. So defining your ability to function by using a language of ADLs helps me understand the impact of these illnesses on your function. IADLs, the instrumental activities of daily living, are higher functional level items. There's a myriad of these. The mnemonic that was used by the Mayo Clinic is shaft. And the logic there was, well, you're going to get the shaft if you're not doing these things. It's harder to function independently in your environment if you can't do these things. So the shaft mnemonic is shopping. Can you get into your environment the food you need, the cleaning supplies you need, the things that help you, like new light bulbs or a shop to get someone to come in and help fix your heater or air conditioner? Can you shop? Can you do your own housekeeping? Can you clean your environment? Can you do your own money management? Can you do accounting? Can you pay bills? Can you use a credit card or a checking account? Can you do and manage money? Can you do food preparation? So different than the ADL of eating, which is simply getting food in your mouth, can you actually prepare that food? That may be you're able to contact Meals on Wheels and have them bring you the food, but you can feed yourself. So you prepare your food by contacting Meals on Wheels yourself, or you prepare your food by putting things in the microwave or reheating items. That's all fine. You're capable of doing it. And transportation. Can you utilize a car or Uber or a bus or walk to the neighborhood to get what you need? What is your ability to use transportation systems? So you can see these are higher level functioning than your basic ADLs. You're going to lose IADLs based upon your illness and your aging before you lose your ADLs. So we know that these are the harbingers of future problems with your ADLs. But if you lose ability to do these independently on your own, there's a lot of systems that are available to help you with some assistance or with full assistance to get these things done. So when you're speaking about your function and how much this illness has hurt your function, using IADLs and ADLs as your language is very beneficial. Now, this graph shows you your functional level here on this axis. Hopefully you can see my pointer for functional level and versus your age. And there is no age written down here. There's no number, but throughout your life, you will lose function. You will go from being very capable and independent to growingly having more and more dependency. I drew the dashed line as what I put as frail state or loss of ability to do your ADLs. You may be functioning just fine and capable of doing all your ADLs and IADLs. You can't go out and shoot basketballs or play tennis or play golf anymore, but you're still very capable, and then suffer an acute heart attack, which is going to take your functional level down to being frail. You may recover some from that heart attack to be back up on a better functional level, but you will immediately lose function, and we'll see and work with you to see if you can regain some of that function. Or you have a stroke, or you have a pneumonia. Somewhere along this pathway, you're doing fine until a major illness hits you, and then those illnesses will knock you down to where you are dependent on people helping you You may be able to come back up and be back on the line depending on how bad that illness is and how much we can recover you. So function does decline throughout your lifespan with no illness. But the chronic diseases take their toll, and any of these acute major things that happen to you will take their toll. So given that, aging well, and how do you best age as best you can, is to maintain your function. Maintaining function is what aging is all about. So I will talk to you about 4 different categories of ways to maintain your function. First is doing healthy, educated choices. Finding ways to avoid a damaging life, finding ways to seek good preventive health care, avoiding a lot of medicines, we'll talk about that, and exercise. So, avoiding damaging things. I've already mentioned smoking. Smoking has been a huge bugaboo for the medical community because not only does it create the chronic lung disease I talked about, but it creates damage to your vascular system. People who smoke have worse kidney functions. So you may have had perfect genes, but if you smoked for 20, 30, 40 years in the middle of your life, that will have damaged what's gone on. So if you're looking for a way to avoid further damage, stopping smoking is essential. Alcohol to excess. You know, there's a great debate in America or even in the world about alcohol and the damage it creates. No one would debate that excessive alcohol is dangerous to you. And it will damage your heart, it will damage your liver, it will damage your kidney. And I have taken care of many middle-aged adults, 30, 40 years old, who have had so much alcohol to excess that they're now losing function and can no longer be independent in their ADLs and will die soon. So alcohol is a huge problem. Obviously, the drugs of abuse. You hear every day about individuals who have taken some type of drug of abuse and they end up having a stroke or a heart attack or die. So those are the big ticket items throughout your life that you have to watch out for. Obesity. Morbid obesity will shorten your lifespan. No question that individuals who are morbidly obese are not going to live a full lifespan as individuals who are not. So having morbid obesity is a big issue. I add in here repetitive trauma. If you want to make a longest lifespan as you can, damage to your joints or your brain through repetitive trauma is a bad thing. You've seen and heard about a lot of the fighters, boxers, or football players who have a shortened lifespan because of the brain disease they've created from repetitive trauma or the joint problems that they get into. Sun exposure. Now, I don't mean going out and enjoying the days of Southern California, but if you enjoy without sunscreen laying on the beach for prolonged periods of time, you will damage your skin and you will damage your life expectancy. So sun is not a good thing for us, and we should be very familiar with sunscreens to prevent ongoing sun exposure, particularly in the environment of where we all live. And seatbelts. Seatbelts are designed to avoid major trauma, particularly through the middle-aged group, but also in older adults. You should never be getting into a car and driving without using a seatbelt. So these are healthy choices so that you will live longer and avoid the things I've put here to make sure that you don't damage yourself and live shorter than your genetics would say you should. Now we get into preventive health care. As I mentioned all along, there are a variety of chronic diseases and precursor illnesses to those chronic diseases that are important to watch out for, to seek doctor advice about. Hypertension being a huge one of those, early lung disease, elevated cholesterols for managing your lipids, managing and keeping an eye out for diabetes. Managing the chronic diseases are a huge part of being able to live your life to your fullest. You should be screened for various cancers. In particular, we have excellent screening for both breast and colon cancer. And you should participate in breast cancer and colon cancer screening. Since I tend to gear this towards elderly, I don't have the third most common screening cancer here, but I should mention it, and that's cervical cancer. Cervical cancer screening through pap smears. If you've had pap smear screening up till the age of 65 and they've been normal, you don't need any further pap smear screening. But pap smear screening, looking for cervical cancer, is one of the common screening things that it works very well. Lung cancer screening in smokers is an essential now recommended screening cancer to look for. So we would do CT scans of your lung at a periodic interval if you've been a long-term smoker. Those are the cancers that we have good evidence for and we do a lot of screening for. You can certainly do skin cancer screening by looking at your skin, and your doctor will do that. But those are the ones. What you notice is missing here that you might have asked or thought about is prostate cancer screening. We've gone back and forth on prostate cancer screening. Current medical logic is not to do prostate cancer screening. We cannot extend your life or make your life better by doing prostate cancer screening. So it's fallen off of the recommended cancer screening. Also not on here that I put in the big asterisk with is people tend to think that their preventive health care is by taking more vitamins or taking some sort of supplements. There is no evidence that vitamins or supplements will preserve function in any aspect of your body. So we do not recommend routine vitamins or routine supplements in any individual. And then most of us have gotten past the idea that a body scan is a helpful thing, whether you've heard of that as a CT scan of my whole body or an MRI of my body or a PET scan of my body or a calcium scan of my heart. There is no recommended scans that should be done in a preventive healthcare way. Preventive healthcare should look for the diseases that you have, manage those diseases, look for the precursor illnesses for those diseases, manage those, and do cancer screening. That's the role of preventive healthcare in trying to help you age as best you can. And then huge in the business of preventive healthcare is making sure you get vaccines that are effective at reducing your risk of getting illnesses. Current recommendations are for four. One, annually influenza vaccine. Influenza vaccine currently is still an annual vaccination. The influenza virus that mutates frequently, we come out with the recommended influenza vaccine, usually available in September, and you should seek from anywhere that you can. And it's such an important thing that our medical community has said you can get it from the pharmacies, you can get it being given to you throughout the community, but you should get an annual influenza vaccine. Tetanus. Many people forget about tetanus because they think it's a younger person disease. Tetanus vaccines only last 10 years, and you should have your tetanus vaccination once every 10 years. Pneumococcal pneumonia is the most common pneumonia people get, and we have developed a good vaccination program against pneumococcal vaccine. The current recommendation in adults, in older adults, is to have either one single injection of pneumococcal conjugate vaccine at number 20. That's just the number of types of serotypes of the pneumonia that's in it, or 2 vaccinations, one that has 15 and one that has 23. And you should have those once after the age of 65, 1 shot of either PCV 20 or 1 shot of PCV 15 and then the PPSV 23. And then a shingles vaccine once. Now there are 2 doses to it, so you get it separated by at least a month. Recommendations are 3 months for a shingles vaccine, but you only need it once after the age of 65. So those are the recommended vaccines for older adults. Not on here also that I have to mention is COVID. We don't know yet. We don't know if we're going to have to get a COVID vaccine once a year, once every few years, if we're going to develop a vaccine that is better against the current variations that are coming up. So I can't place here yet a recommendation, but I would certainly say you should keep your eyes and ears open. Getting COVID vaccinations is an important part, and I'm sure there will be new vaccine recommendations. Medications. I should talk for a minute here about medications. I mentioned early on that I'm going to tell you should stop a bunch of medicines, and here's why. When you look at the number of medicines people take, which is this bottom, and you ask how many people have adverse reactions to those medicines. If it's only 1 medicine, if it's 2, but if it's 3 or more, you're much, much higher to have a problem with an adverse reaction. So if you're taking 3 or more chronic medicines, and medical care right now has even pushed it to say, fine, if you're at 5, I'll accept that. But too many of our seniors are at 8 or 10 various types of medicines. And medications, once you get that many in you, interact with each other and create problems for you. So looking very seriously at the number of medications you take, talking to your doctor about the number of medications you take. Take a paper bag full of your medicines into your doctor and talk about reducing the number of medicines you're taking. There are huge national pushes to de-prescribe, get rid of prescription medicines, and try to reduce the number of medicines people are taking to below 5 for sure, and 3 if we can.
Dr. Dial, we have a question about medication. What if the medication I'm taking are prescribed by multiple physicians?
So one of the problems we get into is that you seek care from a variety of different specialty physicians, and those specialty physicians will prescribe a medicine from their vantage point without communicating to your other specialty physicians. Obviously, my belief in a healthcare system is that you should have a good primary doctor. And that primary doctor should be aware of all the medicines by various specialists and be the focal point that you can use to review those medicines and make recommendations to you and to your specialty physician about which drugs to take. So if you're seeing a pulmonary specialist and an orthopedic surgeon and a dermatologist and a heart doctor, the primary physician is the one who should be overseeing the medicines and making recommendations to you and back to each of those specialists to reduce the number of medicines you're taking. This slide, I hope you see, is the flip of some of that, and it talks about exercise. Exercise is a little bit of the snake oil of the current modern era, meaning I can show you good research studies on how exercise can help with every aspect of any disease you have. So I am going to recommend across the board exercise for every person. Exercise, planned physical activity, structured, repetitive, with an aim at improving your fitness. Not, well, I get up and I walk my neighborhood today, and that's my only exercise. That's good, but it's not sufficient. You need planned, structural, repetitive physical activity. Exercise comes in 4 groups. you're probably worried about, and I will tell you, many seniors don't do cardiovascular aerobic exercises. But that's the one you see at every gym, and you watch people running around your neighborhoods. They're all trying to get their heart rate up, and aerobic exercise is good, but it's not something I would necessarily recommend in a senior population. Resistive muscle strengthening exercise should be done by all age groups, all functional levels that can do it. Strengthening muscles around your joints is the best way to preserve your joints and decrease the arthritic changes, that the arthritic loss of function that's created. So resistive exercises, muscle strengthening exercises are good. Even better are joint mobility, flexibility exercises. Exercises that are going to keep your joints moving, keep your body more flexible. The loss of flexibility, loss of joint mobility is what accounts for a huge amount of senior inactivity, which then leads to loss of function. And then the most important is balance exercises. Finding a way to do exercises that increase your stability will make you safer. Falls are best prevented by balance exercises. So that's the list of the types of exercises, and they're done in the priority downwards that you should do: balance, flexibility, resistive. So if you're fearful of starting an exercise program because you don't want to get on a treadmill and you don't want to run, that's not the important part. Look at exercises that help your balance, your flexibility, and your muscle strength. Like I said, I could show you study after study that's looked at how exercise will improve your heart function, your lung function, and your brain function. And I'm talking about physical exercises improving your brain function. It improves wound healing, immune function, it reduces falling, it keeps you socialized. All age groups, all functional levels should have some type of exercise program built in. And I'm going to do what Nike has done and say, you should just do it. Bottom line, whatever you can do, you should be doing exercises. I would also recommend mental exercises. I went through a large series of physical exercises, but mental exercises are equally as valuable to you. Whether you're doing puzzles or reading books or brushing your teeth with your non-dominant hand, whether you're doing card playing, which is socializing, whether you do it alone or in groups, using your brain is really important. And across all the exercises, if you don't use and preserve your physical function or your mental function, you're going to lose it. And that's crucial as we age, to aging well. I'll put in what George Valette, he's a psychiatrist from Harvard who wrote an excellent textbook on aging well. And I want to make sure I include some of his ideas because he went beyond traditional medical issues into how you psychologically will age well. And his suggestions are to care about other people, to continue to have friends that you are intimate with, that you have conversations with, and developing new friends, keeping yourself out and active, being open to new ideas, being eager to learn, reading books and talking over books, working on puzzles together with people, being cheerful that you will be losing function. That's hard to do, but you will find that you will lose function. I can't prevent that totally. You need to figure out a way of growing old and accepting that that is happening. And you need to retain a sense of humor and play. This is, I think, important information that helps you far beyond what you can see in some traditional medical sense of how do you age well by keeping active and involving humor and play. But I want to finish today with the very end of this picture, because I want you to have not only the ability to age well, but to die comfortably and peacefully as that happens. Because this is what's going to happen to each of us. We're going to be growingly frail. We're going to lose our ability to do our ADLs and ADLs. We're going to need support from caregivers, from nurses. We're going to lose function and need somebody to help us. And then we're going to become terminally ill and we're going to die. That's the end of this aging process. Whatever your chronic disease is that we manage as best as we can, that you seek to try to control with various medicines or treatments, that we seek out ways to prevent or help you prevent, you will gradually lose function and you will lose your independence until you end up in a terminal phase. What's important here is to prepare for that as you see that coming along. You will need to be making decisions about the end of your life as this progresses along. Now that's hard. Many of us are really good at life. And you know, the death part of this is not that scary to people. It's not that I'm going to be dead and gone. What is really scary is this dying process, this process by which you start to see you're losing function and dying becomes where you watch what's happening to you. That's the area that most of us are concerned about. It's not the death, it is the dying process. So I want to help you with how to best maintain and preserve through that time. Okay. There are two things that medicine has available to you, programs that help you through this: hospice and palliative care. We should distinguish those briefly so you can understand the difference. First, hospice. Hospice, you've heard about, is a program to treat individuals who are terminally ill, who are dying, who need medical help and emotional support through that dying process. Care that focuses on how to help their symptoms, how to help their family, how to help them when their life expectancy is 6 months or less. The emphasis is comfort, not curing, and achieving a peaceful, meaningful dying experience. Having a death that's supported and helped for you and your family. Palliative care says it's care focused on helping, like hospice does, but people who are not terminally ill yet. But their illnesses are creating functional losses and making them more disabled, and they have serious bad both aging and diseases. This palliative care is not dependent on you dying. It's dependent upon doesn't matter what your prognosis is. It's looked upon as to be delivered at the same time you're fighting your illnesses. The goal of palliative care is to help you through those illnesses, help you and your family so that you can relieve your suffering and get you the best quality of life while these illnesses are going along. So you're getting traditional medical care. You're doing just fine. You go into the hospital, but you're having more and more episodes of hospitalizations, more and more difficulty with your heart, your lungs, your kidneys, and you add on to your traditional medical care, palliative care. And then as that palliative care plus your traditional medical care manages and helps you along, as that illness gets closer and you need then to shift because it's become terminal and you're now dying, into hospice care. That's the flow of the end of life. Having available your advance directive is really important. Your durable power of attorney for healthcare tells everyone what you believe your healthcare should be and assigns your rights to an individual so they help make decisions when you're not capable of doing that. So it has two purposes. What do you want, and who should we talk to if we can't get decisions from you? There's also another form that's available that I think is important, and that's the POLST form. Here's California's version in pink. POLST stands for Physician Orders for Life-Sustaining Treatment. It's for individuals who are developing these serious diseases, and you want to instruct doctors, what do you want? Here's a blow up of the POLST form so you can see the key aspects. What do you want as far as cardiopulmonary resuscitation? Do you want CPR? Do you want someone to actually push on your chest, blow into your lungs to try to restart your heart, or do you not want that to happen? Do you want, for medical interventions, comfort measures only? Do you want comfort measures plus some limited treatment, some antibiotics, some IV fluids, or do you want full treatment? You want everything that can be done, including intubation and airway management and ventilations and defibrillators. And then the third part of the POLST form asks about artificial nutrition. Do you not want artificial nutrition? Do you want to try it for a period of time with feeding tubes? Or do you want long-term artificial nutrition? So POLST forms are used for individuals as their illnesses are getting worse and worse to talk about what do they want to have happen and to develop a physician order form here, the POLST form, for what you want. So my take-home points from this presentation for you, I hope you hear me say, aging is inevitable. You will grow old. Your only other option is dying. You don't have an option of not growing old. You will grow old. Aging is inevitable. You need to find a way to peacefully do that and to find a way where aging and your mortality you're comfortable talking about. Focus should be on your function, not how old you are. What are you capable of doing? I would suggest that you really do your best to avoid taking too many medicines. You need to get vaccinated for everything that we have available to vaccinate you with to prevent illnesses from developing, and you need to develop a good exercise program. Exercise, exercise, exercise. You should have a durable power of attorney for healthcare, and as you're getting more and more illnesses, you should have a POLST form. I'm in there. Hopefully I've helped you understand how to best age through this, how to preserve your function the longest, and how to get the help you need at various stages through this process. Happy to answer your questions in the chat session, or if you want to come on live and ask, that would be fine.
So I have a couple of questions that came through the chat, Dr. Dial. The first one is, how do I know when it's time to add palliative care to my traditional care?
So I think when you're getting traditional care and it's a simple process in the hospital, you've gone in because you need to have your knee replaced, everything else is working fine, you don't need palliative care added on. You have serious heart trouble, you have serious lung trouble, you're going into the hospital to manage that heart trouble or lung trouble. You have a cancer, they are admitting you to the hospital because you got an infection. You should ask for palliative care to come and be involved. Palliative care will consult with your doctors and you and get themselves involved and then make recommendations for your future. There is no entry into palliative care that's really too early. However, I would say when you end up in a hospital and in need of more care other than a simple short hospital surgical stay.
The next question is, do I need a terminal diagnosis to start a POLST?
You do not need a terminal diagnosis to start a POLST. You need multiple or some serious diagnoses. There's no reason to have a POLST when you're 40 years old and doing just fine. There is always a reason at all age groups to have a durable power of attorney. And the reason you should have a durable power of attorney is that it can be a car wreck when you're 40 that takes it such that your brain doesn't work very well. And now someone's going to have to help make decisions. Doctors need to know who to turn to. So I recommend a durable power of attorney at all ages. And I recommend a pulse form for an older adult or even a younger adult with some serious chronic medical conditions.
If there are any other questions, if you would like to ask Dr. Dial personally, you can unmute and feel free to, ask your question.
Or put it into the chat, whatever you're more comfortable with. Thank you very much for joining us this evening. I hoped I've given you some tidbits and things to think about. If I can say anything, I would encourage you all to do more exercise. I think there's tremendous benefit in getting out and exercising. Thank you for joining us.
Thank you, Dr. Dial. Have a good evening, everyone.